Good evening, delegates and participants. Thank you for joining Shield Connect. And today we are back with our hit series Icons in Conversation with Dr. Ritu on our platform Shield Connect. And it is sponsored by Dr. Ritu Santwani, ma'am. And today's topic is ovarian tissue cryopreservation. And today's icon for the day is Professor Dr. Al-Inani from Cairo. So let me introduce Dr. Ritu Santwani ma'am and Dr. Al-Inani sir. So let me introduce Dr. Ritu Santwani ma'am. Ma'am has done MBBS, MD, FICOG, FIOG, AMR, COG. Ma'am is obstetrician and gynecologist, IVF specialist, and ma'am is founder and CEO of a 360 degrees healthcare studio in Amdar, and also consultant in Inamdar multi-specialty hospital in Pune, and ma'am is infertility test tube baby specialist, NUHS from Singapore, and co-founder of NAAM and board member of SWWC. Now, let me introduce our icon of the day, Dr. Professor Al-Inani. Sir has done MBBS GS, that is a Master of Medicine and Surgery, MD, Professor of Obstetrics and Gynecology. Sir is a faculty member of Qasr Al-Aini Faculty of Medicine, Cairo University. Sir is also scientific editor in BJOG from 2004 to 2019, editor-in-chief of EBWH Journal in 2010 to 2022 presently, and founder of Dirmas. So I welcome both the doctors and I hand over the session to Dr. Ritu Santwani ma'am. Thank you so much.
Yeah. Thank you, Nishan, and thank you, Shield Connect, for providing the platform. So friends, as we all are aware, these days the infertility is on the peak. And so many females are either getting married at the later age group, or if they are marrying earlier also, they have a plan to conceive after 4 years or 5 years. They are having some goals, either some professional goals, or either they are having a priority that first to make a home or first to buy a car, then only they are planning for the pregnancy. So as we all know, as the age increases, the AMH keeps on decreasing. So the ovarian tissue cryopreservation is a very, very important thing. So today, none other than Dr. Al-Inani is with us. Thank you so much, sir, for accepting the invitation. So sir is going to enlighten with all of us regarding what's new and what's in the ovarian cryopreservation. I think first all of us listen to the sir, and later on we can ask the queries, whatever we are having. Once again, I want to welcome to all the delegate doctors who have joined all across the geography. The program is going live on the YouTube also. So Nishan, please keep an eye on the YouTube also. So whatever the questions we will receive, we will take later on also. Once again, a very, very warm welcome, Dr. Ilan.
Thank you very much, Ritu. I'm very glad to be here today. May I ask you to allow me for sharing the screen?
Yes.
My screen, yes. Okay, is it clear for you now?
Yes, clear. Yes, clear, okay. Clear.
Okay, my name is Hisham from Egypt, based in Cairo. I'm a gynecologist, mainly interested in reproductive medicine. And as you know, there is an average age for menopause. This age of menopause usually goes between 40 or 42 up to 55. But sometimes in life, circumstances forced us or forced the menopause to be much earlier, like cancer therapy, like premature ovarian insufficiency. These are certain circumstances that we have to consider how to preserve the fertility for those having special circumstances. So this is the outline of my talk, and it is many outline, but I promise you that it will go through it quickly and without boring you. We will discuss what is ovarian tissue cryopreservation. Simply by its name, it is a fertility preservation procedure It is just freezing of the ovarian tissue, part of the ovary, not all the ovary, part of the ovary. And then we go further and transplant this cryo or frozen part. Why? To retain biological activity and to have children. So this is simply the ovarian tissue cryopreservation. It is a fertility preservation procedure rather than surgical or whatever you call it. But there are many lines of fertility preservation. As you see, in IVF, embryo cryopreservation is very established. Oocyte cryopreservation is becoming more and more popular. IVM has been taken its way, but fading away nowadays. Only very few centers are performing in vitro maturation, IVM. Ovarian tissue cryopreservation is an emerging technique. Ovarian transposition for cancer sometimes is been done. Uterine fixation can be done for radiotherapy. Pharmacological protection with GnRH agonist has already shown no benefit. So what can these trials or what can this procedure coming? Ovarian tissue cryopreservation is emerging as the best solution for those having a tendency or indication for fertility preservation. For a male, it is very simple, just sperm or semen cryopreservation. Even if he is azoospermic, we can get, or obstructive azoospermic, or non-obstructive azoospermic, we can get testicular biopsy, and this even testicular biopsy can be frozen. So for male, it is much, much easier than female. It can be done on 1 hour, not only 1 day. It can be done in 1 hour to preserve the fertility of man. But for women, it needs a lot of procedures. And ovarian tissue, OTC, is becoming the emerging or the alternative technique that is going to take ahead in the medical field. Why? Because there is increased demand for fertility preservation. Actually, there is improved diagnosis of cancer, whether in childhood or in reproductive age. And can you see that breast cancer is now early diagnosis in its first early stage, 1 or 2. The treatment itself has resulted in improved survival rates. For example, again, in cancer breast, it's almost 5-year survival rate around 80%. So the survival rate, increased rate of survival and the increased cure rate has driven these women to ask for fertility. They just not want to be alive, just want also to practice their motherhood. In the same time, the social media has played an important era or a role in the awareness about fertility preservation. Young people are not aware. Families are aware. If one does not know about fertility preservation, one of her relatives will advise her to do so. So there is increased awareness all over the world, not only in Western countries. But for social reasons, there is a tendency for delayed motherhood. For example, in my culture in Egypt, in early 70s, the motherhood was around 24, 25 years old. The average age for motherhood was 24, 25. Now, and while in this new millennium, it is the average age for motherhood is around 33 to 34. So there is a tendency to delay motherhood, and in Western countries up to 40s. So only these motives? No, the facilities are now available. I guess in India, there is a lot of IVF centers and facilities. The technology has much improved. And in Egypt, as I told you, we have more than 280 IVF centers in Egypt alone. Can you imagine the number of IVF centers in Egypt serving around 100 million of population? People are now asking about the quality of life. They don't want to just live. They want a better quality of life. And there is improved desire for families, especially in the last 10 years. Now the family life is now gaining more and more popular in Western countries. It is the patient choice that can allow for fertility preservation or does not desire any fertility preservation again. So we have motives and we have facilities. That's why ovarian tissue cryopreservation is becoming an emerging technique, but not only this factor, but because there are certain populations that need this technique specifically. Those who are going to have immediate gonadotoxic treatment. Immediate gonadotoxic treatment need not to be delayed for cancer treatment, for example. So the best is just to take part of the ovary, freeze it, and then transplant it later on. The ovarian tissue cryopreservation is particularly the only solution for fertility preservation in prepubertal women, female. In prepubertal children, ovarian tissue cryopreservation is the only way to preserve fertility. We heard about this germinoma in age 14 and 12. We heard about sarcoma in the age of 13, leukemia, about all these factors. But those also for hormone-sensitive malignancies, example, cancer breast with positive receptors for estrogen, positive estradiol receptors, then they will require better to have OTC, ovarian tissue cryopreservation, than to do oocyte cryopreservation or embryo cryopreservation. Just mention the hematological disease like leukemia, like those having hematopoietic stem cell transplantation. They are usually taking whole body radiotherapy. Or those having autoimmune disease, we have a special clinic for systemic lupus erythematosus and another clinic for that of autoimmune thyroiditis and autoimmune diseases. That's why taking chemotherapy. These are taking chemotherapy while they are fertile, but because of the chemotherapy, it will destroy the ovarian reserve. Rheumatoid arthritis. We have another clinic for rheumatoid arthritis that in severe cases will take chemotherapy to alleviate their symptoms. Recently, have been proposed endometrioma as a progressive disease, reducing the ovarian reserve. Why this would be candidates for ovarian tissue cryopreservation. So we have candidates for OTC specifically that can benefit from it, not only the oocyte cryopreservation or the embryo cryopreservation. And now there are certain social indications for ovarian tissue cryopreservation. Those are requiring the child, delay the childbearing. They don't need to cryopreserve the oocyte, just to cryopreserve that ovarian tissue itself. BRCA1 and BRCA2 genes carrier. As you remember, Angela Jolie has removed her breast and both ovaries because she has BRCA1 and BRCA2 positive. So they decided to avoid this cancer by removing the estrogen supply of her body. Even though some scientists are now taking or advocating what is called the natural HRT. You know, the synthetic HRT has been previously proposed to alleviate menopause symptoms and to improve health of women, but synthetic have markedly declined and only advised during the hot flushes or the first year of menopause. Now, scientists advocating the use of OTC as a method of natural hormone replacement therapy. Just replace part of the ovary and then it will produce, transplant it, and then it will produce natural estrogen, natural for these women, which will improve her health and prevent menopause or delay the menopause. And I'm not talking about fantasy or dreams. Actually, it has been done in UK and in Egypt, but we are going through this lecture. But it took place in several places in the world, specifically in UK and United States. But it seems that it will be a chaos of OTC. No, we have to be medically oriented. We have to judge things in a very good way. And that's why scientists develop what is called selection criteria, Edinburgh selection criteria for ovarian tissue cryopreservation. Women should be less than 35 years old. That means that she should have a good ovarian reserve. No chemotherapy or radiotherapy before the OTC. As you know, chemotherapy or radiotherapy can destroy the ovarian reserve. And only if her survival chance is more than 5 years. Actually, this is a mistake in my slide. It should be more than 5 years. Survival rate more than 5 years. Premature ovarian failure, the risk is less than 50%. And patient should go through consent for herself if she is an adult or her parents if they're a child. And of course, there is no existing children or not pregnant before. So these criteria are used to select candidates for ovarian tissue cryopreservation in a country where OTC is sponsored by the taxes or by the government. So again, why OTC specifically? Why not to do ovarian tissue cryopreservation? Why not to do embryo cryopreservation? Because we have several advantages over these two. Only prepubertal. There is no place for oocyte cryopreservation or embryo cryopreservation or even semen cryopreservation in prepubertal children. And it can only reverse, the only way that reverses the ovarian insufficiency. When you extract part of the ovary, then you replace it again, you are reversing the ovarian insufficiency. Ovarian insufficiency is regarding the oocyte production. But the most important advantage over embryo cryopreservation and over the oocyte cryopreservation is that there is no delay. Once the patient is indicated for OTC, you can do it in the same day or the day after. That means there will be no delay at all, and she can start chemotherapy just after the ovarian tissue cryopreservation, after taking part of the ovary. This is the most important advantage that OTC can offer over the other fertility preservation lines. There are other advantages. We don't need ovarian, and we don't need sperm in these cases. Just if the patient is single or divorced, there is no need to do embryo cryopreservation. There is no increased estrogen, so there is no more risk for cancer breast. There is no delayed treatment, as I said. There is no IVF done with its huge number of injections. And one important criteria, in IVF or in fertility preservation line, like embryo cryopreservation or oocyte cryopreservation, you will always have a fixed limited number of gametes. For example, the maximum will be 20 gametes, for example, or 20 embryos. That means we have always a limited number. But in ovarian tissue cryopreservation, it depends on the part that you use in taken from the ovary, and it will result in more number and more than 10,000 eggs, more than 100,000 eggs. So there is no fixed number of eggs or embryos can be limited with OTC. I guess all of you are now impressed by the advantage of OTC, but we have disadvantage, we have obstacles, we have other disadvantage. It includes 2 surgical procedures. First, you have to take part of the ovary, of course, and then you have to implant this part later on, whether 2 years, 3 years, 5 years, but you have to do it, to graft it again. Second, it is still experimental. We don't know exactly the success rate of ovarian tissue cryopreservation. These are attempts all over the world, attempts trying to do this, but not as a standard procedure. So one of the important disadvantages that it's always done in patients with critical situation, in cancer patient, in rheumatoid patient, in systemic lupus patient with severe condition. So we don't have a control group. We don't do ovarian tissue cryopreservation for fertile couple just to have a control group. So we don't have adequate studies with adequate control group on to evaluate the level of safety and efficacy of OTC. The more the advantage. What if I get patient more than 35 years old? What if they have low ovarian reserve? MH is less than 1. Should I discard her for ovarian tissue cryopreservation? What about hematological cancer, hematological diseases like leukemia? Can the ovarian tissue biopsy still cause contamination, or is contaminated with the malignant cells? So if I graft it later on, it will cause the recurrence of the malignancy. What about ovarian tissue cancer, ovarian cancer itself? Can we do it in the other ovary, not documented to have malignancy? But the main disadvantage for OTC that it is always time limited. It is always has a duration, maximum 4 years. The graft, the batch that we implant, it has a limited duration, has limited time of activity. Usual maximum is 4 years. So these are all of disadvantages that make it the progress of OTC slow all over the world. But it is not obsolete. It's not a dream. There are more than 100 babies that has been done, delivered after ovarian tissue cryopreservation. There are many teams all over the world that are performing ovarian tissue cryopreservation. So let's start with the clinical part. How does we perform ovarian tissue cryopreservation? This is a very interesting question. How do we do it? First of all, you have to put in your mind that it is a multidisciplinary team. It is not a gynecologist that only will perform. He is not a magician. It needs a gynecologist, it needs anesthesiologist, it needs the oncologist, it needs the medical oncologist to make a plan for every step. And it needs the patient approval and treatment of cancer itself to discuss the risk of this procedure and how does it affect the level of the disease itself. So we have to make it in a team rather than individual doctor activity. If we decided to do it, then as a gynecologist like me, will do the technique in a very simple way. We will do first ovarian tissue harvesting. We will collect part of the ovary and then cryopreserve this part. And then we sew this part. We let it to be warm so we can transplant it later on. It is 4 steps, 4 different steps. 1, 2, 3, 4. Let's start with the first. Ovarian tissue harvesting is usually done by laparoscopy. Sometimes in my country, Egypt, we do it by mini laparotomy to take a good part of the ovary, or even if the surgeon is not laparoscopic oriented surgeon. One important question that has been asked, when to do it? You can do it any day. Once the patient is diagnosed to do the ovarian tissue cryopreservation, you can do it in the same night in the operative theater, because it will take you just biopsies, and these biopsies will be dissected into strips. Usually we take from one ovary, we leave the other ovary intact, and then we transmit to the lab, the IVF lab, within 30 minutes, so that these strips will not be destroyed during transportation. And one fact that you should always keep in your mind, that never to use cautery. Never to use cautery during your laparoscopic surgery, because this is the bed where you are going later on to implant this tissue again after 2-5 years, but this is the place. So don't destroy the bed. Don't destroy the soil where the implantation could be done. Why laparoscopy? Because the complications are usually very limited regarding this. Well, let's see a small, very small, brief video about this. Sorry. This is how it's available on the internet, I guess. It's very simple. As you see, we will take part of the ovary, just part of the ovary, not the whole ovary, of course. And then we take the second part of it, dissect these parts into strips, take these strips under complete aseptic conditions, just strips, and then put them in specific media regarding the tissue harvesting. So we usually dissect the tissue under strict asepsis. Please consider this point, strict asepsis. And we repeat wash the strips by saline in the operative theater to remove any blood. We need as clean tissue as clean as possible. And this, if it is clear, then we go to put it in what is called safe media, the exact media where we do the embryo or the oocyte denudation and collection. And then we transmit these tubes in ice to the IVF lab. The distance between the operative theater and the IVF lab should not be more than 30 minutes by any way. So you always keep this in your mind. And in the IVF lab, please consider again the strict aseptic condition where you are going to deal with this tissue processing to cut in pieces, cut in slow, thin pieces like this, using it under the laminar flow to ensure to avoid any contamination. And then we start the next step where we do what is called the cryopreservation. So we have now strips of ovarian tissue. Now we will start with cryopreservation. We don't know actually which type of protocol should be applied, the slow freezing or the vitrification. You see, in UK, they depend on slow freezing and they claim higher results of sowing with this slow freezing. But in Scandinavian countries, they use the vitrification, and vitrification is now all over the world. So Scandinavian countries use the vitrification for the ovarian tissue cryopreservation. And if you notice with me, this what is we obtain tissues as clean as possible. Then we try to dissect the fat or the medullary tissues from the cortex itself. And this is again a picture of it. We remove the tissues from the cortex to reach finally this clean tissue, which is the ovarian cortex. And this ovarian cortex will put into strips. Strips uniform in length, uniform in size, uniform in thickness, uniform in thickness. And usually it is done in the lab with even very slow tools, tools forceps, very easy, not to harmful these tissues, to obtain them as clean as possible. And we throw away the redundant tissue. This is the redundant tissue. Can we cryopreserve the whole ovary? It is doubtful. It is questionable. Of course, it will give us a long-term effect. But first of all, and the most important, there will be a thromboembolism in the pedicle. This is a very high possibility when you put the whole ovary in the cryoprotectant media. So it will result in thromboembolism in the pedicle. This will be subsequent fracture of the pedicle, fracture of the ovarian tissue, fracture of the ovarian surface, and decreased permeation of the cryoprotectant material. So it will develop finally ice crystals. Imagine having intracellular ice. The results will be very poor. With the results will be very poor when you transplant these strips again. This was when you do the whole ovary, the ice crystals will be deposited markedly inside the tissues. The third question, or the third step, is the ovarian tissue sowing. We still don't know whether we have to do slow sowing as in UK or short sowing like vitrification as in Scandinavian countries. Usually this is within 12 minutes, while this is around 30 minutes, almost the double. This is no cryoprotectant media, but here there is a reduction of the cryoprotectant media every now and then. So we don't know, but we follow here in Egypt, we follow the British way. The fourth step is a very interesting step. It is the ovarian tissue transplantation. Where to transplant it? It is usually done by laparoscopy. Can be done by robotic surgery. Of course, it is now a fashion to do laparoscopy by robots, but can be done percutaneous. You can implant it in the subcutaneous tissue, in the forearm, here in the forearm, or in the axilla, here. It can be done even in the lower abdomen. So let's see how it can be done, the ovarian tissue transplantation. Very easy if you have good hemostasis and don't use diathermy. If you don't use the diathermy, you will have a bed that can be healthy for implantation. Or you can do it just under the skin of the abdomen. Very, very easy way, and can be done there if you want to have what is called natural hormone replacement therapy. But if you want natural pregnancy, you have to put it back in the ovarian fossa. If we did transplant it, how to follow up? A very important question. We have two ways of follow-up, clinical and laboratory. Actually, we usually start by the lab because it is the most quick and sure area, objective area. We are recognizing the FSH every month for this case. We do estradiol level assay every month. We do the AIM anti-malarial hormone level after 3 months or 6 months. But of course, the patient herself should ask for clinical follow-up by the occurrence of menstruation, by the occurrence of ovulation, by the definitive way, which is the occurrence of pregnancy. So the follow-up is easy and very simple, but it takes duration. The least is 3 months. The maximum is 2 years. So we have to wait and even give sometimes ovarian stimulation, controlled ovarian stimulation for these cases. All of you should ask this question. Did it succeed? What is the success rate for it? In fact, it is now more than 130 live births have been documented after ovarian tissue cryopreservation. This means that ovarian tissue cryopreservation was so old, more than 20 years ago, yes, but it now takes the upper hand because of fertility preservation concept. Ovarian tissue cryopreservation has been done in the year 1999 for twins. One sister with premature ovarian failure and her sister donated her ovary to her. It will restore the ovarian function and may result in natural conception. Even meta-analysis has been published on the outcome of ovarian tissue cryopreservation and auto-transplantation. So even this, it is now becoming more and more popular. When you take part of the ovary, you should consider that you are removing part of the ovary. This will affect the ovarian reserve of this ovary, and this will result in a decline in the ovarian reserve. In unilateral oophorectomy, there is a decreased rate of fertilization rate in IVF and clinical pregnancy rate by IVF regarding the ovarian reserve. In Egypt, how far we did? We did almost the first clinical cases for ovarian tissue cryopreservation as a teamwork, as I told you. And until now, we have more than 30 cases. In the year 2021, we have 17 cases for 2 cancer ovary cases, 1 huge endometrioma, 5 cancer breast cases, 3 cases cancer colon, 1 case even during cesarean section. She was 41 years old and asking for lactating her baby for 2 years. So it considered herself too old for having another baby, asked for ovarian tissue cryopreservation during cesarean section, and 5 cases for social indication just because they were around 37 to 39 years old and single women. What next for ovarian tissue cryopreservation? It can be done by partial decortication, can be done by cesarean section for elderly prima gravida. So there is a potentiality for wider use of OTC here, at least in Egypt, where the concept is actually accepted by many women. Alternative to ovarian tissue transplantation, specifically if she doesn't want pregnancy, we can do the IVM, but this is unsuccessful here in my country, and it was never been used in human life, but it has been done in animal models. so I cannot comment on this in my culture. But uses beyond fertility preservation for postponing what's called natural menopause. We have an actress that around 46 years old, and she is afraid of being menopause. She is scared of being menopause. That's why she asked us to take part of her ovary, although the AMH was less than 0.5, but she insists to take part of the ovarian cortex, freeze it, and then when she is planning to put it back when menopause is becoming more and more close, knowing it by hot flushes, she is going to have what's called natural hormone replacement therapy to avoid the menopause. But more commonly now in my culture is the endometriosis. Endometriosis, case stage 4, where there is bilateral endometrioma, and patient is around 27 years old. They asked now us to have fertility preservation by using OTC, ovarian tissue cryopreservation, for huge endometrioma, as AMH is declining rapidly within these cases. Surprisingly, now doctors, not patients, doctors who have been old enough to witness the ovarian tissue surgery, what's called wedge resection. This was done about more than 30 years ago in my country, wedge resection for the ovary for cases with PCO. Now, they said when we do ovarian tissue wedge resection, don't throw the tissue, just cryopreserve these tissues for these women having PCO. It would be better than over laparoscopic ovarian drilling. So we have 2 doctors in my country that for cases with PCOS, documented of course to have PCOS, they consult the patient or counseling the patient to do laparoscopic biopsies from this ovarian tissue cortex, and then freeze it and preserve it later on. It is the same concept of ovarian wedge resection that can stimulate the ovary to do ovulation by itself. So this uses beyond fertility preservation, and it's not frequent in my country or even in the world, but it is attempts from different gynecologists to use it beyond fertility preservation. The most important question, what is I'm talking about? Is it ethical or it is not ethical? Of course, there is a debate. Extending clinical indication beyond fertility preservation has been debatable. Why to do this? Is it safe? Is it really safe? What is the limit for ovarian tissue transplantation? When can we tell the patient not to do transplantation of her ovarian tissue? Is there a time limit for storage? In my country, there is no time limit for storage, but consensus for 10 years. But we don't have regulations for this. Is it actually ethical to harvest and freeze ovarian tissue without certainty of success of ovarian tissue transplantation? In my country, it is usually a private work, not governmental work. So we do it in a private sector. So we take money for it. We take money for this procedure. Is it ethical to take money for procedure without certainty of its success in ovarian tissue transplantation? So we have many issues to discuss here in Egypt and I guess all over the world. But anyway, this is a very emerging procedure. I guess it will prevail more or less soon because the facilities are there, the awareness is there, and the indications are there. So thank you for your attention. Keep in your mind that ovarian tissue cryopreservation philosophy is keep it till you need it. If you don't need it, it's okay, but keep it. It is still early to mention many conclusions, and we have very limited information on ovarian tissue cryopreservation. Thank you very much for your attention.
Thank you, sir. Thank you. Thank you so much. A very nice lecture. You have covered almost all the points. Sir, we have received some questions. So I'm taking that. Sir, this question is received by Dr. Sena. She is joined from the Delhi. Her question is, how long the cryopreserved ovarian tissue can be preserved for using further for success rate?
We don't know. We don't have limit. It can, in my country, we just mention 10 years arbitrarily, so we cannot comment or answer this question. But we believe in my culture that we should replace it as soon as possible to avoid the medical legalities, etc.
Yeah, thank you. Thank you so much, sir. Sir, this is another question by Dr. Joshi. Dr. Joshi has joined from Motihari, Patna. His question is, can the ovarian tissue cryopreservation can we offer in the BRCA patients?
Yes, in both BRCA1 and BRCA2, before doing ovariotomy, we can take this part of the ovary and preserve it. It's an ideal question. It's an ideal answer again.
Yeah. So thank you, sir. So there is one question from Dr. Yukti Bhardwaj. Yeah, thank you, Dr. Yukti, for joining. Our question that what are the contraindications for this ovarian tissue cryopreservation?
Ovarian cancer itself is a contraindication, of course, because mostly you cannot guarantee the safety of the biopsies even after frozen section. But as I said here in my talk, we did 2 cases of ovarian cancer, ovarian tissue cryopreservation after doing frozen section for different biopsies, because we removed both ovaries. So we cannot consider that it is totally safe, but we did it. Again, the contraindication, the patient is stage 3 or 4 cancer. Don't do any OTC in a patient with poor prognosis. Why to do it? There is no value for it.
Thank you so much, sir. Sir, there is one more question from Dr. Saxena. He has joined from Lucknow. His question is the efficiency of OTC procedure questionable in the advanced age? Shall I repeat the question, sir?
Yes.
Yeah.
Please.
So, is the efficiency of OTC procedure is questionable in the advanced age?
There is no enough publication, insufficient evidence to answer your question. However, in advanced, the women who ask for OTC are usually advanced age. This is from my experience in my country. But we limit this to a patient who is having cancer only. But again, we do it for elderly primary gravida during cesarean section. I am making it very clear because these women are trying to get more and more children. Usually their babies are IVF babies, so they tend to reserve part of the ovary in the same setting during cesarean section. Yes, we did it. Yes, we did it, even in advanced maternal age. Thank you.
Yeah, thank you. Thank you so much, sir. Nishan, these are some questions what I have received in my YouTube channel. Please check what are the other questions you have received, and then you can take it, Nishan. Dr. Nishan?
Yes, ma'am. Yes, ma'am.
Yeah.
Let me check, ma'am.
Yeah.
So, ma'am,
Yeah.
I received one question also. Should vitrification versus slow freezing can be used for ovarian tissue cryopreservation for fertility preservation in cancerian patients?
What was the question again? I didn't listen.
Yeah. Should vitrification versus a slow freezing process be used for ovarian tissue cryopreservation for fertility preservation in ovarian cancer patients?
So again, we don't have any controlled studies. We don't have studies that perform it with slow freezing versus with vitrification. We don't have studies in cancer cases versus non-cancer cases. We don't have any control group, and this is a major weakness in this area. We admit that.
And we receive one more question. What is pregnancy rate and live birth rate for OTT, and in which location it is better?
Which better? The pregnancy rate is better?
Like what is the pregnancy rate and live birth rate for this ovarian tissue transplantation procedure?
It is too early to mention figures for pregnancy rate after ovarian tissue cryopreservation. It's too early to mention this. We don't know. We don't know. It is an emerging technique. So we have to follow up or to have to wait for studies to be published. Thank you.
Yeah, still a lot of work is going on. Lot of studies are going on this. So thank you so much.
Yes,
Nishan,
I would like to thank you all for your attention. And
sir, one more question is there. Sir, which is the standard surgical procedure to collect the ovarian tissue for this procedure, OTC procedure?
It's a very simple instrument. We don't have to use a specific technique or a specific instrument, just punch biopsy from the ovary, and when get strips, but healthy strips, about 1 centimeter in length and 1 millimeter in thickness. This is very important. The thickness is very important to allow the cryoprotectant media to go through all the tissue, to go all through the strip. Then we can believe that the strip is adequately preserved all through the thickness. Okay.
Thank you so much. Sir.
Thank you very much. And I would like to thank you all.
Yes, sir.
Thank you, sir. Thank you.
Good
Thank
night.
you so much. Yeah, good night.
Good night. Bye-bye.
So, bye, sir. Bye, sir. Thank you so much. So with this, we are winding off for the session for the today. So friends, do join us on next Thursday, 10th November. The same time, 8:30 p.m. Indian time, we are going to discuss about the early pregnancy scan. So whatever your questions related to early pregnancy scan, we can take it on next week. Next week, we are having with us Dr. Kuldeep Singh with us. So be prepared with your questions. And on the 17th November, we are having Dr. Nasreen Sheikh, the CEFOG General Secretary, all the way from the Bangladesh, is joining with us on the topic for the osteoporosis and menopause. So stay tuned with us for many more informative sessions. We will be back soon again with other sessions. Till then, bye-bye. Good night. Thank you, Nishan.